This is Willie Kemp. This is Disorders of White Blood Cells Part 4. And remember, there are 6 parts to the entire lecture. There's web pages for me and Dr. Hughes's questions, and there's my Twitter locations. I haven't posted in a while, but I'm going to go back to posting more frequently. And remember, I'm a forensic pathologist. I'm not a hematopathologist, but I have a very strong interest in both general and systemic pathology, and I have a very strong interest in teaching medical students. So read my disclaimers. If you do not agree with them, then stop watching the lecture. And one more disclaimer, and then also, if you're interested in understanding my ideas behind how I teach and stuff like that, then watch the introductory presentation. Here's a list of references that I used, all very good. I wish, like Dr. Stern's book, The Symptom to Diagnosis, Excellent Way to Form a Differential Diagnosis, I wish that had been available when I was in medical school. And once again, I want to say thank you to the University of North Dakota's Department of Medical Laboratory Science. They had a fantastic collection of hematopathology, peripheral smears, and bone marrow smears from a wide range of disease processes I had the chance to photograph and use a lot of in this presentation. So at the beginning, we have a question. Pause, answer the question as best you can, and then we'll discuss it at the end as usual. Like I said, this is a good way to, it helps retain material in the lecture because it gives you something to focus on as you go through. So plasma cell neoplasms, they're actually relatively common. Multiple myeloma is actually the most common bone tumor. I remember I was asked this question actually on rounds one time, I think in surgery, and they asked me that, and I remember that was the answer. So basically these are, they're also sometimes used the term plasma cell dyscrasias. So basically it's a neoplastic proliferation of plasma cells, and then the plasma cells produce the immunoglobulins. So if you have a neoplastic proliferation of plasma cells, they will be producing immunoglobulins. They can also make excess light chains as well, and sometimes just light chains. And so what happens is, because the plasma cell is clonal, meaning it's derived from one cell, it produces one immunoglobulin. So this will produce what's called an M spike, or now maybe they're using the term M component, but I'll show you on the electrophoresis where the normal immunoglobulins are variable in size somewhat, and so they cross over a wide range. With an M spike, they're all of one type, so you'll see this prominent spike. Different forms of plasma cell neoplasms. Multiple myeloma is one. Monoclonal gammopathy of undetermined significance. This one, they have basically no symptoms really, but they oftentimes have that M spike. And so once again, it's a monoclonal gammopathy. It's one clone producing this one type of immunoglobulin, but they don't necessarily have the plasma cell numbers or stuff like that, but oftentimes they'll go onto it. You could have an immunocyte-associated amyloidosis, and then amyloidosis is also associated with multiple myeloma and production of the light chains in that. A Waldenstrom's macroglobulinemia is where they produce too much IgM, and IgM is pentavalent, so it just makes the blood more thick, and so it'd be hyperviscous. And then sometimes it says rarely you can have just a heavy chain disease where you just get free heavy chain fragments, and that one's associated with lymphoplastic lymphoma, as is Waldenstrom's macroglobulinemia. So this is my drawing. This is not a complete serum protein electrophoresis. There are more bumps than this, but this is the far one, and this is the one that represents the immunoglobulin. So to the top left, you can see it's kind of like a nice little hill. So basically, your body is normally producing a wide range of immunoglobulins, which vary a little bit in size, and so therefore spread out more like this. However, to the bottom right, when you have a multiple myeloma and you produce one type of immunoglobulin, because you have a neoplastic proliferation of plasma cells, or an MGUS, just this production of this immunoglobulin, it's only one type, and so that's why you see this spike, and that's the M spike or the M component. So here we have, this is basically what you can see on the slide is a whole bunch of plasma cells. So a lot of these have the characteristic features of it. So the nucleus is going to be eccentric off to one side. You get the clock face chromatin. So you basically get little bundles of chromatin around the edge of the nucleus. And then oftentimes you also see a perinuclear clearing. And you can see that, especially to the bottom right. You can see this what they call perinuclear Hoff or this perinuclear clearing where it's much, much lighter pink. And so these are the features of plasma cell. So if you had this in the bone marrow, that'd be consistent with something that's a multiple myeloma. If you had this in one mass, it'd be a plasmacytoma. So multiple myeloma usually occurs around the age of 70 years. There are different translocations that can be found in it. One is immunoglobulin heavy chain on chromosome 14 to a cyclin D1 or cyclin D3 genes. Translocations can also involve MYC on 8, a 13q deletion, 17p deletion, and then obviously if it involves TP53, the 17p deletion has the poorest prognosis, has a very poor prognosis. So what you would see is pathologically, you'll see a plasma cell infiltrate in the bone marrow, or unless it's a plasmacytoma, then you'd see a mass. They produce lytic bone lesions, and then you can get the free lambda and kappa light chains, what they call Bence-Jones proteins. So the immunoglobulin won't go into the urine, but the light chains will. And then because of that, that can lead to what they call a cast nephropathy, where you get casts in the kidney that can actually cause damage to the kidney. If they have lytic bone lesions, they're going to have hypercalcemia because they're breaking down that bone and they're going to put more bone in the blood than what is normal. And then also, if they have lytic bone lesions, they're going to be at risk for a pathologic fracture. And then the characteristic feature on peripheral blood smear is the rouleau, where the red blood cells look like they're stacked like coins. Immunophenotype, it's CD138 and CD56. So this could be one that is useful to know because they're, it's not like all the different ones that CD19, CD20, knowing that's a B cell marker is good, but this one, it's beyond that, and it kind of sticks out. So this is multiple myeloma. So the top left is a radiograph. So all the little darker spots, those are all the lytic bone lesions. So you can see the relative whiteness of the cranium and then all the little black spots within. And I'm showing you to the right what I saw. So all the different tan lesions, you can see the branching of the middle meningeal there, the grooves in the bone. So we're looking at the undersurface of the cranium to the right, and you can see all the tan masses. That's all multiple myeloma. And so you can see to the left, it is eating away at the bone because you don't see any bone in those spots. And so it's a lytic bone lesion. And then here's an example of rouleau. So you can see the red blood cells line up like coins stacking on top of each other. So multiple myeloma is most commonly IgA or IgG, but it's said rarely it can be IgM, IgD, or IgE. And then also, as I said before, sometimes patients only have light chains. And then also, interestingly, but rarely a myeloma can be non-secretory. So with this, what you'd be doing is you looking at a bone marrow biopsy and seeing a proliferation of plasma cells. But since it's non-secretory, you wouldn't see the M spike or that because it's not producing immunoglobulin, which makes sense because the normal job of the plasma cell is to make immunoglobulin, and neoplastic cells for a while oftentimes will do what their normal cell type they're derived from does, but as they become more neoplastic and more mutated and everything like that, then they lose the ability to do what they're normally supposed to do, and that's why you might not see them secreting immunoglobulin anymore. So it says the neoplastic cells upregulate rank L, and then rank L is going to stimulate osteoclast activity, and so you're going to get a breakdown of it. You can also see, like I said, I mentioned it, solitary plasmacytoma, where you see a neoplastic proliferation of plasma cells, but forms a mass. And then there's another one they talk about called a smoldering myeloma, which sounds a little bit like MGUS, but it's a little bit different. And there's the underlying thing for it. So a smoldering myeloma, you have no symptoms, but they have a really high M spike. The concentration is greater than 3 grams per deciliter. Whereas with an MGUS, a monoclonal gammopathy of undetermined significance, the M spike is smaller, so less than 3 grams per deciliter. So similar, but a little bit different based upon the amount of immunoglobulin it's putting out. So I mentioned it, but a lymphoplasmatic lymphoma is one associated with the Waldenstrom's or the heavy chain disease. So this is also found in older adults. They have a mutation in MYD88 usually. As with other lymphomas we're talking about, fatigue, weight loss, hepatosplenomegaly, lymphadenopathy, and then because they are oftentimes producing IgM, the Waldenstrom's macroglobulinemia, you can see features associated with hyperviscosity of the blood, so sometimes CNS type changes, and that's on the next slide. And so pathologically, you see a bone marrow, it says lymphocytes, plasma cell, and plasmacytoid lymphocytes, meaning they're kind of lymphocytes, but they look kind of like they're working their way toward plasma cells. And then when they produce the immunoglobulin in the cell, you can actually see that. You can see protein accumulations, little nice pink round globules. Those are the Russell bodies. And then immunophenotype, they're CD20 positive, and they produce surface immunoglobulins. So the Waldenstrom's macroglobulinemia that I mentioned, with production of IgM, since it's pentavalent, it makes the blood really hyperviscous. That hyperviscous can cause different things, visual problems. You can imagine really thick, sludgy blood going through the vessels. They can get kind of generalized, non-specific neurological symptoms, headaches, dizziness, deafness. It can interfere with platelet function. I think, once again, that's basically based upon all the protein in the blood blocking it. And then the IgM can precipitate at a low temperature, which kind of makes sense based upon cold antibody hemolytic anemia. And at cold temperatures, your tips of your fingers are going to be the ones probably at most risk for that, where you see Raynaud's. So with this, they'd be more like you see that. And then remember, with Raynaud's phenomenon, if it's primary, it's usually good prognosis. But if it's secondary, as it would be in this case, then it's much worse. And it could actually lead to, more commonly, ischemic injury and damage to the tips. So, and then as I mentioned before, you can have a cold antibody hemolytic anemia because you're producing IgM, which is the antibody that is most known for participating in that. Okay, so I just put the slides in to tell me where I'm at in the presentation, and also just to give a little break. So this is a field across from our house. I live in Billings, so you can see the rim rocks back there in the distance. And I just thought it was kind of interesting, the nice untouched snow, except for the couple tracks right there, and then the track going alongside the road. A lot of fun to shovel. Okay, hairy cell leukemia. This one is found, it has actually fairly classic presentation. It's usually found in older males. They get a pancytopenia, so all the hematopoietic cell lines are decreased, and splenomegaly. And then the pathology is very characteristic, the hairy cells. So you see these elongated kind of hair-like fibers from the neoplastic cells. They're CD20, but kind of unique, CD11C and CD103. And like I said, so I think personally, when there's like one or two CDs that are specific for one or two conditions, that's a lot easier to remember than just trying to remember all the ones that might be 19 and 20. Just my thought. And then the mutation associated with it is BRAF. So here's hairy cell leukemia. And as I said, they cause a pancytopenia. So actually you don't see a lot of neoplastic cells in the smear, in my experience. I mean, I've only looked at a couple of them, but on the slide, oftentimes you're trying to find where are they. So I put up there the history, and I'm trying to do this to link the pathologic image with the disease process, and then the immunophenotype, the 11C, and the CD103. Mycosis fungoides and Sézary syndrome. This one actually originates from helper T cells. Oh, sorry, I meant to fill in the demographics, I forgot. But it's older patients usually. And then pathology, it's known for causing cerebriform-like. So the nuclei actually kind of looked like they have gyri, like they're convoluted. It's a T cell, so CD4. And then it produces a rash, and then that progresses to a plaque, so slightly raised, and then not a tumor, which would be really raised. And then Sézary syndrome is more of a generalized exfoliative erythroderma, and then you see a leukemic component, and that would be the neoplastic cells with the cerebriform appearance to them. So here's that. So these are the best ones I have. I think if you look at the ones at the arrow, and actually the one that's to the very left of the screen, you can just see the nucleus looks like it's lobulated, and that would be that cerebriform appearance. Adult T-cell leukemia lymphoma. This one is not as common in the United States. It's found mostly in Japan, the Caribbean, and West Africa, and it's associated with HTLV1. So this is an important association to know. It's a T cell, so it's CD4 positive. As would be expected, they get lymphadenopathy, they can get hepatosplenomegaly, they can get hypercalcemia, and the disease is rapidly progressive. Pathologically, it says they're usually multilobated, so they kind of look like a flower. And then HTLV infections can cause other things as well too, including a progressive demyelination of the brain and spinal cord, the disease being tropical spastic paraparesis. So I think the biggest one there is really the association of the HTLV1, because it sounds like without it, you wouldn't get that disease process. So peripheral T-cell lymphoma, and T-cell lymphomas, from what I know, what you see in Robbins and what I remember and what I've seen, there's a whole bunch of types of them, but they're all pretty rare. So if the biggest ones I think would be mycoses fungoides and the one associated with HTLV1. The other ones are in Robbins, so I'm putting them in here as well. But I think there's many that are not actually in Robbins, but they're pretty rare. So you can see lymphadenopathy. You can see fever, eosinophilic weight loss. And then the markers there. This one, though, the ALK positive, this one it seems like came up during residency a lot, this anaplastic large cell lymphoma being ALK positive, and there is a ALK negative version of it. But the thing about it that really I think is kind of neat is the morphology of it, the large anaplastic cells. And so that's kind of stands out, it seems like, when you're talking about lymphomas. Since, diffuse large B cell they're large, but they're all about the same size and shape, it seems like, for the most part. Whereas this one, they can have very odd appearance to them. So I think it kind of stands out. And then the ALK association with it. And then the ALK leads to activation of the RAS and JAK-STAT pathway. It can be found both, usually in children and young adults, and has a fairly good prognosis. Unless it's found in adults, and that's oftentimes ALK negative, and those have a worse prognosis. And then large granular lymphocytic lymphoma, most commonly in adults. Mutation is STAT3. The clinical presentation, you really see no lymphadenopathy. It says, and then it says the NK variant is very subtle. Pathology is large granular, so large lymphocytes. The immunophenotype is there. The natural killer cells are CD56. So I include these because Robbins only touches on them a little bit, so I figured I'd put some of the stuff in there. But these are really rare conditions. This one, though, I think comes up a little bit. The extranodal NK T-cell lymphoma. It presents as a nasopharyngeal mass. It has a very poor prognosis associated with EBV. And I think this is the one, I could be wrong on this, but I think this one sometimes they call it lethal midline granuloma, but I'm not 100% certain on that. But that's also a nasopharyngeal mass that can be very aggressive. Okay, so here's the question. So stop it, look at the question, and try and answer it, and then we'll go through it. Okay, so 61-year-old male presents to family physician with a complaint of abdominal fullness, which would go along with a lot of things, but splenomegaly, because as the spleen enlarges, pushing on the stomach. In addition, he has recently been seen in acute care clinic for pneumonia. So if he has an infection with what we're talking about, you want to think of some things like, if he's bleeding, has infection, has anemia, the possibility of some type of marrow involvement or pancytopenia or that. A review of systems reveals that when working in the garden lately, when he nicks his finger, he bleeds longer than normal. So bleeding, and then a complete blood count reveals a hemoglobin 11.2 grams per deciliter and white blood cell count that was low. Given that neoplasm source of his condition of the following, which genetic or phenotypic marker would be expected. So he's an older male. He has pancytopenia. He has splenomegaly, and so CD103. So it fit along with a hairy cell leukemia. So then at the end, as done with the other ones, I suggest that you pause and then use reflection, go back through and think of, okay, what are 5 points that I made during the lecture? I hope I made 5 important points, and this really helps you cement that material. And like I said, Make It Stick talks about a medical student who went from bottom of the class to top of the class using this one technique. So I've started using it, and I really try and promote it among the students. And it's why I don't put a summary in there, because if I put a summary, you wouldn't be inclined to necessarily do this. So, and then there's my kitty cat, Moach, and she is really bored with my presentation. I hope you all got more out of it than she did. And thank you.